continue with the next topic from a very special colleague of mine, Dr. Dimolitsa. She is an intensivist here in PICU in our hospital, MITERA Children's Hospital, and she will talk about postoperative bleeding and how we manage.
Okay. Greetings to all the colleagues around the world. So I'm going to be speaking to you today about postoperative bleeding and the management strategy that we follow in our department in the Pediatric Intensive Care Unit of MITERA Hospital here in Athens. So, as you already know, postoperative bleeding is a major problem in children with congenital heart defects undergoing complex pediatric cardiac surgery with cardiopulmonary bypass and results in significant postoperative morbidity and mortality. But how do we define and classify postoperative bleeding in children? Unfortunately, when referring to the pediatric population, there's no one-size-fits-all, and protocols and guidelines made for adults cannot be easily applied on children. That's why there's a huge heterogeneity among centers in terms of management strategies, transfusion thresholds, quantification of blood loss, etc. So the risk factors associated with a higher incidence of bleeding are the ones you can see in this image. And now we know that children at high risk are neonates and young infants due to their immature hemostatic system, those who undergo complex, urgent, especially reduced surgery, probably because of their increased cardiopulmonary bypass time and deep hypothermia, children with low body weight because of a higher degree of bypass hemodilution, and children with cyanotic disease, mainly related to impaired fibrinogen and platelets function. So identifying a patient at risk is the key because this way we can be prepared to prevent, minimize, and manage postoperative bleeding the best way possible. So a patient who is at low risk will probably have acceptable rates of bleeding, which means that the chest tube output will be less than 2, maximum 3 milliliters per kilo per hour for the first 2 or 3 hours after ICU admission, less than 1 milliliter per kilo per hour for the next 3 hours, and less than half milliliter per kilo per hour by post-12-hour closure. As you can see, the trend should be downward, and the patient will probably be hemodynamically stable. So in this case, we apply the general hemostatic measures and follow a restrictive transfusion strategy. The general hemostatic measures are avoiding hypertension, keeping the patient normothermic, avoiding acidosis, and correct electrolytes, especially calcium, because calcium ion play a crucial role in the path of coagulation. The restrictive transfusion strategy is a way of minimizing allogenic blood transfusions, and it is based on optimizing fluid management in order to avoid hemodilution. We try to minimize all the flushes and extra fluids given to the patient. We try to reduce amount and volume of lab blood draws to avoid iatrogenic anemia. We try to tolerate anemia, if possible, to use purified coagulation factors whenever possible and if needed. And later on, we try to treat anemia with iron therapy and stimulate erythropoiesis. So the restrictive transfusion strategy is safe, but under strict monitoring of end organ oxygenation parameters, such as peripheral saturation, NIRS, diuresis, lactate levels. But in children with hemodynamic instability, it's of questionable value. Moving on to the next case scenario, a patient who is at high risk will probably have significant bleeding. The chest tube output volumes will be more than 3 milliliters per kilo per hour for 3 subsequent hours, or more than 5 milliliters per kilo per hour for 1 hour. Well, this patient needs close monitoring because ongoing bleeding may cause further coagulation problems. We'll have to notify the surgeons because this patient might need their exploration in the following hours. We try to secure hemodynamic stability and check the coagulation status of the patient with ACT, PT, APTT, INR, fibrinogen levels, platelet count, and thromboelastography. And of course, we treat the patient with transfusion and correct coagulation. Now, the optimal transfusion threshold after cardiac operations in children has not been established yet. It seems logical that children with a cyanotic disease require a higher level of hemoglobin in comparison to children with no cyanosis. There are a few studies like the ones you see here that concluded that even this particular population can tolerate lower levels of hemoglobin without a significant difference in overall outcome. The consensus recommendations for red blood cell transfusion practice in critically ill children suggest that children who undergo biventricular repair require no transfusion if the hemoglobin level is over 7 grams per deciliter and the child is hemodynamically stable. But for children with single vertical who undergo stage 1, stage 2, or stage 3 palliation, they require no transfusion if hemoglobin level is over 9 grams per deciliter. But as you can see here, that is a weak recommendation. So until further data are available in the literature, we try to keep our hemoglobin goals over 8 in children with no cyanosis and between 11 and 14 in children with cyanotic lesions, depending on the degree of cyanosis and the underlying condition. Now, we treat coagulation the following way. If ACT is over 150 seconds, we might give an extra dose of protamine. If APTT and iron are prolonged, we will transfuse with fresh frozen plasma. If fibrinogen levels are less than 1 or even less than 1.5 and there's ongoing bleeding, we will give fibrinogen. And if platelets are less than 50 or even 100,000 and the patient is bleeding, we will transfuse with platelets. If this don't work, then we will try desmopressin as well. But besides conventional coagulation tests, we routinely use thromboelastography, which analyzes each phase of the clotting process. So let's see how it works. A patient's whole blood sample is placed into a small cup at 37 Celsius degrees, and then a metal pin is inserted into the center of the cup, and the mechanism starts to spin the cup slowly. So as coagulation occurs, the pin adheres to the clot and then starts to move with it. Thus, the movement of the pin is proportional to the clot strength. And then a wire connected to the pin creates a computerized graph, like the one you can see on the right side of the slide. So in the beginning, there's no clot, so the pin won't move. But as coagulation occurs and the clot starts to form, then the pin starts to move more. And as the clot breaks down, then the pin moves less. So basically, thromboelastography is a measure of an entire life cycle of a clot. We have our results in 45 to 60 minutes, and what we get is a pattern like this. This is for normal coagulation. The first part is the coagulation part, and the second is for fibrinolysis. So our time, react time, represents the time that it takes for a clot to start forming, and it's usually 5 to 10 minutes. And if it's more than that, then we'll have a problem with our coagulation factors, and we'll have to give plasma. K time, kinetics, is the time until the clot reaches a fixed strength, which is usually 1 to 3 minutes. And if it's more than that, then we have a problem with fibrinogen. The alpha angle that you see represents the speed of fibrin accumulation, and it's normally 53 to 72 degrees. And if it's less than that, then we have a problem with fibrinogen again. MA is for maximum amplitude, and it's basically the maximum strength of the clot. So it's usually 50 to 70 millimeters, and if it's less than that, then we'll have a problem with platelets. And the treatment would be platelets and or desmopressin. LY30 is the percentage of the clot in lysis 30 minutes after the clot has reached its maximum amplitude. The normal values are between 0 to 8%, and if it's more than that, then we have excess fibrinolysis, and we have to treat the patient with tranexamic acid. Now, the patterns that we can get from thromboelastography are basically these. The ones on the top are for normal hemostasis. The blue ones are the ones that we see in hemorrhagic situations, the pink in thrombotic situations, and the green in fibrinolytic situations. So the conventional coagulation tests combined with TEG, with thromboelastography, gives us a better idea of what's going on with our patient. So they allow us a more targeted therapy of coagulation deficiencies. So next case scenario, a patient who is at a very high risk for bleeding will probably have massive bleeding. the chest tube output will be more than 10 milliliters per kilo per hour for at least 1 hour, and this patient needs immediate transfusion, red blood cells, fresh frozen plasma, and platelets into a ratio of 1:1. And this patient, of course, needs immediate surgical evaluation because that kind of bleeding is a strong indication for re-exploration. And what we can do in the meantime is repeating the coagulation tests and treat accordingly. And of course, keep our patients normothermic with adequate calcium levels and no acidosis. The tricky scenario in PICU is the bleeding patient on ECMO, because in this case, we have to keep a balance between adequate hemostasis without clot forming. So as you already know, the patient on ECMO will be under heparin, so it's not uncommon to see bleeding more than 10 milliliters per kilo per hour. So in this case, we try to keep a lower ACT between 160 to 180. We're more aggressive, so the platelets should be over 100 to 150,000, fibrinogen level over 1.5, and at this point, we might consider giving tranexamic acid. And if our patient is still bleeding, then he will probably need surgical exploration. We might lower ACT even more at approximately 140 to 160. And if the patient is still bleeding and no surgical bleeding points identified, then we'll have to seek for hematological advice, keep fibrinogen level over 2. And at this point, we might consider stopping heparin. As you can imagine, this is a very difficult decision. The whole team must be present, and of course the perfusionist must have a clean, primed circuit ready just in case. The other options that we have at this point is considering factor 7 or prothrombin complex, and if we have done our jobs right, then the bleeding might stop. And at this point, we can restart heparin at a lower dose, approximately 5 units per kilo per hour, hoping that we won't have to start all over again. So that was about all. A few take-home messages. Children under 1 year old with a low body weight and cyanotic disease who undergo complex cardiac surgery are at high risk of postoperative bleeding. Restrictive transfusion strategy is safe, but under strict monitoring of end-organ oxygenation parameters in hemodynamically stable patients. Thromboelastography combined with conventional coagulation tests offer a goal-directed management of severe post-op coagulopathy. And of course, every pediatric cardiac center must have an algorithm-based management of post-operative bleeding. Thank you for your attention.
Okay. Thank you, Dr. Dimolitsa.
Thank you very much.
For a very great presentation.